This is The Medical Show with Scott Johnson and Dr. Jerry Tolbert.
Hello, and welcome to another episode of The Medical Show. This is episode 3 of our first season. I'm Scott Johnson. That is Dr. Jerry Tolbert. Hello, Jerry.
Greetings.
Greetings. How the heck have you been in the week since we last talked?
Pretty good. Had a good July 4th holiday weekend. Hung out in Orlando for a little while.
I saw that. You're doing, I saw the Hulk at one point.
Yes.
I don't know where you were. I can't remember, but you went places where I assume it was Disney, right?
It was actually Universal Islands of Adventure is where the Hulk is. That's where we were.
Okay.
We spent some time in all 3 of the original Universal parks. The newest park, the Epic Park, we haven't gone to yet.
Yeah, they kept the Hulk around there because they didn't have the Disney deal yet, so I guess it's still... It's weird, isn't it? A little bit weird.
So they have comic book Marvel.
Yeah.
So the Fantastic Four, the Hulk, Spider-Man, they have rides that are themed around a lot of the older versions of those properties. The newer stuff in California is all going to be at Disney. But here in Orlando, or not here in Orlando, I'm not in Orlando, but in Orlando, a little north of here, they still have the licenses. So it's all original comic art, a lot of Adam Kubert art that they've got scattered all over the place, and
that's awesome.
Hopefully it sticks around because I like the Hulk ride. It's a pretty cool roller.
Yeah, that's pretty rad. Keep the MCU over there on the Disney stuff and let the comics live on their own.
Yep.
Well, there you go. Another indicator that you all. I know what's going on right now. Everyone in their heads going, "Man, I wish my doctor was a nerd and I could talk to him about this stuff." Because their doctors are boring. Jerry's over here talking about the Hulk and Kubert art, which is pretty rad. Anyway, we're glad to be back, and man, we got a lot of messages and questions last week. That was pretty crazy, Jerry. Lots of it.
Yeah, the more episodes we have, the more questions we get, and we wanted specifically to thank everybody for sending those questions, both through the messages and in the Discord channel. We've been trying to answer things as they come up, but if there's something big, we want to make sure that we talk about it here on the show.
Yep.
So we've got a question from this week. Do you want to read that one?
Yeah, I'll go ahead and read it. Here is one from an anonymous person who said, I have a question for the doctor. My husband has been on Mounjaro for type 2 diabetes for about a year now. They have slowly been increasing his dosage, and with each increase, his appetite decreases. He often forgets to eat because he doesn't feel hungry. When he does eat, it does seem to be enough to provide good nutritional value, or it doesn't rather seem to be enough to provide good nutritional value. He gets full so quickly that it's hard for him to even consume a small protein shake. What can I do? So right on the legs of that whole episode we did about weight loss and some of the myths and the stuff going around, and one of them was about these semaglutide drugs and what people do with them. What do you say about somebody who's, they're not eating enough now? It's kind of the opposite problem than they used to have, I guess.
So it can be complicated, just like everything else.
Sure.
And what we talk about mostly is making sure that you're getting good sources of the enriched foods. So foods like the protein shakes are going to have things added to them, especially the vitamins and minerals that you're talking about. Mm-hmm. So having those as an additional source of food in between meals is a good way to avoid getting too full during meals. We also talk about eating much smaller meals multiple times a day instead of 3 big meals. And that is a safe thing to do. There's nothing about eating multiple meals that is going to cause a whole lot of trouble as long as you're limiting calorie intake, which is how you make the weight loss work. That's how the medicines actually help. One of the ways.
Because you still have the full day's amount of, like we talked about last week, calories. So you don't want to have 8 separate meals of 1,000 calories each.
Right.
You want to split whatever your daily is. Let's say it's 1,800 calories. You want to split that up evenly with your 5 meals or whatever you decide to do. And you're not giving yourself more spikes or causing issues like that, right?
Yeah.
Okay.
Exactly. And not only that, if you're only eating a couple hundred calories at a time, it may seem like you're not eating much, but if you do that 5 or 6 times a day, it adds up. And so it's safer that way to make sure that you're getting enough nutrients. The other thing that you can do in that situation is make sure that you're taking a multivitamin, because that'll give you any of the minerals and vitamins that you're missing out on in some of the foods.
Sure.
You don't necessarily absorb it quite as well as you would from your food, but it's still a good way to get those things supplemented in and to avoid deficiencies, which is what it sounds like she may be worried about there.
Yeah. I had to go to a doctor once who said, I was tired all the time. And so she did a full panel, and she came back and she goes, I don't know why, but your vitamin B is in the toilet. And I was like, probably because I'm not supplementing. Is that a thing as you get older? She goes, no, you're just not eating stuff with enough vitamin B in it. So Let's get you on supplements for a while, but let's also increase these things in your diet. And it worked. And I could tell a massive difference. So you may think like, big deal, vitamins. What's the big deal? It's a huge deal. Some of this stuff, like D and B, like they make a giant difference in your day. And I think isn't there there's stuff tied to B helping you metabolize other vitamins. Like you can't, I forgot the exact thing. I heard this somewhere.
Okay.
So one of these,
Carter were talking about it on the most
that's what it was. Yeah, we were talking about it on the show. So what is that whole deal? It's something about iron, maybe? I don't remember.
So kind of. So vitamin B and folic acid are both necessary for producing red blood cells, just like iron can be.
Yeah.
So you do need a good source of vitamin B coming in, vitamin B12, but also vitamins B6 and B1 are also very important for normal metabolic processes.
Right.
Typically, we're going to get those out of most of our foods, especially if you're eating things that contain any kind of grains or lean meats. But for vegetarians and vegans, sometimes that can be an issue. Or for folks that are trying to watch their intake of grains to avoid carbohydrates, again, there are reasons. We often see those kinds of deficiencies in alcoholics as well because they have trouble digesting those and absorbing those vitamins.
Oh.
And they don't take in enough of them. So it's kind of a double whammy.
Wild. I didn't know that at all. So wait a minute. How does that manifest in somebody who's alcoholic?
So,
just lower and they drink a lot, or how does that work?
Partly, yeah. What we start to see is something, and this is true of any B12 deficiency, it eventually, at a high enough level, or for a long enough time, is going to cause something called macrocytic anemia. The red blood cells, instead of being normal sized, they get kind of big.
Yeah.
And you may have fewer of them. And so we see that on a normal blood count that we would do just to look at blood cells. And we can decide from that we need to start supplementing that. In fact, for most folks, if there's a question after like bariatric surgery, that's another place where we sometimes see this, where part of the stomach is missing and you can't absorb the B vitamins through that part of the stomach because it's not there anymore.
Sure.
So what we start doing is we supplement, whether through injection or with like a B complex vitamin, to make sure that people are getting enough so they can make those red blood cells. B6 and B1 are also involved in a lot of other processes. So they affect nerves and brain tissue. They affect the muscles. They can affect the skin. We can start to see things called angular cheilitis when you don't have enough of those vitamins. So there's a lot of different ways that it manifests depending on what's going on. And then from history, from talking to the patient, developing that relationship with them, we can find out, oh yeah, maybe you are drinking a little bit more than what your body is able to handle.
Now, let me ask you this. As today's patient here on the air, and you know this about me, but for some reason in the last, 6 months or so, I have these intermittent, like almost rashy breakouts on my cheeks, sometimes up here on my forehead. And they sometimes are pustules, sometimes not. Sometimes they hurt, sometimes they don't. Sometimes they fade for no reason and they're just gone. Other times I need to, kind of treat them with over-the-counter stuff. Can some of that stuff can be caused by deficiencies in certain vitamins, that sort of thing?
Yeah, it can. It also has other etiologies, other reasons for happening, and so it can be complex. Again, just like everything else.
Yeah.
Exactly. We have to look at what's going on with the skin itself, how often it's happening. That can be a relationship. There can be a relationship between those things and vitamin deficiency, but it can also be something with the bacteria on the surface of the skin just setting up shop and doing some dirty work. So there are a few different things there that happen. It's part of the reason why it's so difficult to get a solid treatment. Yeah. So we try a few different things. We've got a couple of different sort of cocktails, if you will, combinations of different types of drugs that make a difference in swelling or inflammatory changes. Then also things that are going to be antiseptic that are going to kill off things like bacteria or even fungi that can cause that kind of irritation.
Well, the great news is it's like being 16 again. So I need to go to prom. I need to be embarrassed. I'm ready for all of it. Let's do it all over again, guys. Let's go back. All right. We're going to get to the
Mythbuster moment.
Yeah.
Hold on.
Okay.
Mythbuster moment.
All right, go.
So acne is not just a teenager thing. It does flare up when our hormones are going crazy as a teenager, but acne is a lifelong thing because we have these bacteria that live on the surface of our skin that if we get in the wrong place or have the wrong kind of nutrients coming to them, they will overgrow. So that is a myth that acne goes away when you get older. It gets less, but it can still happen. And that doesn't mean there's anything wrong with you if it's happening. But if it's causing you distress, make sure you talk to your doctor.
It was a big lie for my parents, though. They used to say, hey, one day you won't have them ever again. Like you'll grow out of it, they said.
Culture said that for a long time.
They're lying. That culture lied to me. Well, that's interesting. There you go. So we need one of these, like something whenever you bust a myth. We need a sounder for that. We'll figure it out. Anyway, let's get to today's stuff. As everybody out there may be aware, if you're paying any attention to recent events, a gigantic legislative bill was passed by the Congress, originally proposed by the Trump administration, with a whole bunch of changes to a whole bunch of things. And we're not going to get into the entirety of the bill. We want to focus on the implications and impacts in the medical arena or in healthcare in general. And there are a few, probably even a few that many of you have not heard of. But we're going to focus in on a couple of things here. But what are the core healthcare changes proposed in this bill in summary form, and how do they differ from existing policy before these changes?
So the biggest and most talked about is the cuts to Medicaid. It's about $1 trillion over the course of about the next 10 years. And the work requirements that they're adding into Medicaid, so you have to prove that you're working at least 80 hours per month and have some type of, or have some type of disability that precludes you from working in order to qualify. So those are the biggest changes that people are talking about right now. The chances of that causing loss of insurance for people that are currently qualify for Medicaid are high because it adds administrative burden. And by that, we usually mean paperwork or forms that need to be completed or deadlines that have to be met. And so when you add those new restrictions in, folks that already don't have a high income or don't have access to certain resources are going to lose out on their eligibility to be able to get Medicaid, which is the primary insurance for a lot of folks. So the estimations right now are somewhere between 8 and 14 million people could potentially lose their insurance just because of those changes. And that's partly because of expansion that happened during COVID for extra Medicaid availability.
Yeah.
And that is being kind of rolled back and pulled back, as well as there are new requirements for getting into Medicaid.
So it's more rollbacky.
Well.
It's more than just the rollback from pre-2020, right? We're talking about additional steps beyond that to make cuts. Okay. Yeah, I just think it's important to mention because a lot of times people will say, oh, everyone's whining or complaining about a thing, and they don't realize that this is actually just back to where it was pre-pandemic, and now that we're in a better place with the pandemic, we can actually roll that back, and that's a savings there. But this is not just simply that. There's more to it.
Correct. And also taking into account that every year, even before the pandemic, even before really, since as far back as I can remember, even before I became a doctor, there have been pushes to cut Medicare and Medicaid both year over year as far as reimbursement to physicians and hospitals, because the point of the program is to stay solvent and to keep going. And every year things get more expensive. Right. So there's an increase in terms of like cost of living and other things that happen that have to get figured into that. So every year there's a big push in the healthcare circles, the American Medical Association, the American Academy of Family Physicians, American College of Physicians. They're all pushing to say, no, don't take away our reimbursement. Don't make these things less. Don't cut Medicare and Medicaid reimbursement to the physicians because that's already happening. So this is on top of all of that. That's already there baked into the system.
So it's already a thing that happened every year, sounds like.
Right. On the physician side, which again, this is not an oh, poor me. We make more money than we probably should as doctors, but that's a whole other set of discussions.
Right.
The whole point of the discussion is this is now going to be pushing more into people getting health care, not just about me getting paid.
Right. Right.
So it's a much bigger deal in terms of that, but it's on top of all of these other things that are already part of those cuts.
What about the ACA, the Affordable Care Act exchange plan stuff? Is that going to affect people?
It is, because what they're doing is changing the requirements and the eligibility that could potentially lead to about 8 million fewer people being eligible for those exchange-based plans. So those aren't Medicaid. There was never a government option baked into those, even though there was a lot of misunderstanding about that, things that got called Obamacare. It was essentially private companies that were offering insurance at a whatever rate that the market held to people that otherwise wouldn't be getting insurance because of they didn't have employer-sponsored insurance or for whatever reason.
Right.
But a lot of those folks are people that made too much money to qualify for Medicaid, but didn't make enough to buy a standard plan on their own. And the requirements now have changed for that.
That was 100% me before this.
I think I was reading somewhere around 34 or 36 million people that got that exchange insurance expansion when the ACA took when those were put in place.
Right.
So it was several million people that have access to that insurance right now, and potentially up to 8 million of those could be losing that access because of the requirements and how they're changing them.
Yeah, I'm a little nervous about it, to be honest.
Rightly so.
Yeah, we're in the whatever. We live in a time where hey, do something cool, be an entrepreneur, figure it out, and then you're like, oh, but yeah, how do I pay for insurance though? Jeez.
Traditional business doesn't like entrepreneurs, so yeah.
No.
So
They do not.
the other big thing that came out of this that we want to make sure that we talk about, and this is not an oh poor me, but there's something called a provider tax that's going to change. So for hospitals, nursing homes, and independent physicians, the amount that the fees that are charged, the amount that is taxable is dropping, or changing, so that there will be fewer taxes charged on what we make. So our reimbursement seems to be apparently, if you look at it from a 30,000 foot view, our reimbursement is either staying the same or going up slightly because they're taking out fewer taxes. But that tax money went to the states so that they could expand Medicaid services. So it was a way for the states to generate money to be able to cover all of the expansion and the ability to cover extra people. But it was at the expense of some of those fees that were going to places like hospitals and nursing homes, because those people that were using the Medicaid and the expansion dollars, the tax dollars that were coming to the states, were putting it back into the system on the other side. So it was kind of a lateral move, but it still got the hospitals that extra money, the nursing homes that extra money. And so there are going to be reimbursement changes most likely for hospitals and for nursing homes, because there are going to be fewer people that are able to afford using the hospitals and the nursing homes, which means the overall money going back to the hospitals and the nursing homes is going to decrease. And you may have heard about that. They were talking about rural hospitals and other places that are potentially going to be closing or in danger of closing because they were already working on a budget deficit, and now they're going to be even further in debt because of that.
Yeah, I heard the number 1 in 4 rural hospitals are going to go away. Do you think that's a reasonable number?
Yeah, you see that statistic. There's something like 238 hospitals across the country that could potentially be affected fairly soon, within the next couple of years, not necessarily right away, but over time. And that number is probably a low estimate, to be honest.
I mean, a lot of this thing and there's a lot of stuff in courts right now. Like, as soon as the thing passed, immediately lawyers kick into gear and they start making legal challenges. I don't know how much of those are being aimed at any of the medical system changes, tweaks, or otherwise, negative circumstances of the bill. Do you know how much of that is targeted by these court challenges, and whether or not any of that has any traction to, I don't know, some of that stuff get picked out and removed?
I haven't seen anything, but that doesn't mean that there isn't anything. I can tell you that the large organizations are mainly kicking back against what happened once the bill passed, this idea that they're going to try to, a lot of politicians that voted for the bill are saying, well, we're going to try in the 10 years to make up for it and try to roll some of these things back so that they never actually happen, which again, whatever, that's political machinations, why start it in the first place if you're trying to make it never happen. Right. But in terms of like work requirements and the provider tax changes, there are people that are lobbying against that stuff taking effect, but I don't know of any legal action. Okay.
Well, here's hoping in a couple of cases.
For sure.
Let's talk about who benefits most from these changes and who is being most negatively affected. You've kind of alluded already to anybody who is dependent on Medicaid, at least in some categories, are going to be, it's going to be real bad for them. Any other areas of impact that we haven't talked about?
So most of the folks that are being affected are going to be the disenfranchised, however you want to qualify that. Essentially people that don't have resources, that don't have access to lawyers or plenty of time to make phone calls and do paperwork. They're the folks that are going to suffer the most. The rural hospitals that don't have a lot of resources, independent physicians that are working by themselves, they're going to have some of these issues that are going to be affecting them.
Yeah.
There are going to be decreases in pregnancy care. So maternity care and labor and delivery services are going to be affected because that is a big part of Medicaid, is taking care of pregnant women and taking care of children right after they're born. So there are a lot of things that could be put in jeopardy and a lot of people that could be put in jeopardy. The biggest concern on the medical side, there are a lot of people that are going to avoid seeking care because they don't have insurance, and that means that their chronic diseases are going to get worse over time. Mm-hmm. And we're going to see an increase in the number of people that need, high-level care or have to go to the hospital more frequently for problems of exacerbation of diabetes or exacerbations of COPD or other things that we can now, if they have insurance, take care of a little bit more easily. Yeah. But if they're uninsured, now they're relying on hospital-based programs like the one I work for, or community health centers, which are also having trouble getting funding.
I've heard a lot of arguments for those organizations and more privately, maybe privately funded, but privately bolstered programs, especially in small rural areas, that it's actually good that they're going to have to take on more of a burden to. It's your typical pull yourself up by your bootstraps kind of argument, but how much of that resources are resources? They're limited by nature, by definition. So, do you think that holds any water when people say that?
No, because there are two things that are working. So first, let me say that they did put in an 11th hour provision that they were going to give about $50 million to the rural hospitals to try to bolster them so that they don't go into debt.
Yeah.
That's about a third of what those hospitals are projected to actually need over the course of the time that they're giving that money. So, take that for what it's worth. But they're also kind of hamstringing the people that are most likely to go back into a rural area to practice. They put in caps on med student loans. And so we talked a few episodes, or back in the last episode, about how we had to live on loans. We weren't allowed to work where I was at medical school unless we had a special dispensation. And the amount of loans that I took out and that I finished with exceeds the cap that they've put on federal student loans at this point. So had I been in medical school right now, I would not have been able to live. I couldn't have fed myself or paid my bills if they capped the federal student loans without taking out private loans, which oftentimes have much higher interest rates. And so what that essentially means is anybody who is in that situation, who is either doesn't have a lot of income or doesn't have somebody that's helping them pay for things or can't co-sign on their loans, and they don't have good credit, say, they're not going to be able to get medical school loans, which means they're not going to go to medical school. And it's usually people that come from rural areas that have those problems, and people that come from rural areas are the ones that go back to rural areas to practice, which means we're not going to have a bunch of people going back into the rural areas to practice to take care of these patients. So,
all right. So where the heck were we?
I would say, don't make me say all that all over.
No, what you said was we got it all. We're totally good. I just don't remember where it ended.
We were talking about the med students. You're not going to have anybody coming in.
Oh, right. Okay, so I'll do it like this with this transition.
Yeah.
So, how about med students in terms of the loans? Because there's stuff in here about loans, and it's not very clear to me as someone who doesn't understand this stuff what the actual impact of these loan changes are. So maybe explain those a bit. So
to put it in perspective, I'm going to talk about some things that people usually don't talk about in real numbers. I'm going to tell you how much I came out with in terms of student loans. I had $250,000 in student loans when I graduated from medical school, and that included my undergrad, but that was all of my student loans.
And we're talking, just for context, you said it last week, but like 2002, 3, what was it?
So 03 was when I went into medical school. 08 was when I graduated.
Okay, so from 03 to 08, that accumulated. That's roughly the total amount, roughly minus. I mean, does that include interest and all that, or no?
No. So there was no interest charged on those federal loans while you're actively a student, and actually some of it gets deferred as a resident. So no interest there. It was just that was the amount that we borrowed. So we basically got about $50,000 a year that we were using to live on and then pay tuition. And tuition has gone up drastically in the last 10 years. Yeah. So from that standpoint, people are going to have to come out of medical school about $300,000 in debt, usually bare minimum. If they're going out of state to medical school, it may be far more than that.
Right. Yeah, you have benefits for being in the state you live in or whatever.
Yeah, right. In-state tuition, just like any other normal college, for medical school, it's the same way.
Okay. So now there is a cap on federal loans, as I understand it. How does that work?
So the federal-backed loans, the ones that are not private loans that you would have to take out with just a bank, you have to have your collateral and do all of the paperwork and things like you do for like a mortgage, say. If you're doing a federal loan, you don't have to do as much of that stuff. They do still take into account economics of income and parent income and other things, but it is federally backed. They've capped that. I think the last thing I read said $150,000 a year, or $150,000 total.
Well, that's about half what you told me you're going to need. That's not good.
And that was 10 years ago. So more than 10 years ago at this point. So it is a big deal. And it is going to keep people that otherwise would go to medical school because the loans allow them to. It's going to keep them from going to begin with.
Right, which means you add to the shortage we already have not recovered from, right?
Exactly.
Ugh. Yeah, that's a weird knock-on effect I don't think anyone's thinking about, or they weren't thinking hard enough about.
or they were thinking about it in a different way, because a lot of times, I don't want to get too political. We've said this before, but one of the things that is an unintended consequence of this is that a lot of folks that aren't white like me, that don't have a lot of resources like I may have had access to potentially. You know, my dad is a doctor, but he was actually just barely out of practice when I started going to medical school.
Sure.
So he wasn't paying for anything. He had his own loans that he had to pay for.
Right.
So, but people that don't have the same privilege level that I had absolutely couldn't do it without those loans. And so this is going to disenfranchise a group of already disenfranchised people even more.
Great.
And that may have been part of the target. And we don't know that. I can't say that with any definitive, truth behind it. I don't know. I like to think the best of people until they prove me wrong. But in this case, it's hard to see that.
Yeah. It's easy to go down that road that this was a strategic choice that has that outcome. But you're right. Part of what makes it strategic is there's really no way to say whether that's what they meant to do or not.
Yeah.
Right. Well, all right. Let's talk about the Advisory Committee on Immunization Practices, or as some call it, the ACIP. And this is an impacted thing. Some of this was going on with or without the bill. Like the bills has less to do with this than anything. This is more like, hey, how do we approve vaccines, and how do we know they're effective, and then how are we going to distribute them? What's our recommendations? How do doctors respond? Like there's a lot of questions around that. So let's go through the ACIP stuff. What exactly is it, and what role is it playing in shaping U.S. specifically vaccine policy? So
ACIP is a subset of the CDC. They're under the auspices of the CDC. They are a committee that is supposed to be nonpartisan, that is supposed to be appointed and changes from time to time, but it's supposed to be experts in their field. So people in immunology and virology, people that understand infectious disease and biostatistics. They are planning out what is called the immunization schedule. And so we have a children's immunization schedule and an adult immunization schedule. It tells you what doses, how often, what times between them, what exceptions need to be made in extreme situations or for certain disease processes. They are basically planning out the safest and best way from a scientific standpoint to make sure that the entire population is protected as well as possible.
Right.
That's what they're doing.
That's the job of the ACIP. That's what's supposed to be.
That's the job of, the ACIP, ACIP, Advisory Committee on Immunization Practices, whatever you want to call it. That is their job. They are there to make sure that we get the best possible information and that it's updated on a routine basis. Every year they meet, they talk about what's going on, they put out new recommendations. In fact, this past year we got new recommendations for pneumococcal vaccines, the vaccines against Streptococcus pneumoniae, which is a specific bacteria that can cause pneumonia, can cause a few other types of diseases, causes like things like ear infections and other stuff.
Yeah.
There's a vaccine against that we give to adults once you hit age 65 previously. Now it's been lowered down to age 60 and in some cases even age 50. And with certain conditions, you could get one today, no matter how old you are, if you need it. But those decisions about when to give those vaccines and how to give them can be kind of complicated. And we want to make sure that you get the maximum immunity out of the vaccine. So that's what this committee does. They come up with that idea.
And that data and that evidence comes from where? Where do they get all of that?
All over the place. So it's coming from studies of the vaccines, both aftermarket and studies that are done as far as safety and efficacy ahead of time. Yeah. There's lots of information that's going into those vaccines. In fact, in medical school, to supplement my income at times, but also because I was interested in the science, I actually participated in a bunch of vaccine studies.
Oh.
So there are researchers across the country that do, usually in a university setting, they will do trials on vaccines to see what the immune response is, how often we need to get the shots. And so essentially what they're doing is they draw our blood, they see what's going on, they give us a vaccine, and then they check our blood again, and then they may have a protocol for giving that vaccine 3 times or 4 times over the course of a year or over the course of a couple of years. And they collect all of that data and they look at, okay, how effective is this vaccine when we give it in this way?
Okay, so this all makes sense to me. Mm-hmm. What's changing? Like, for example, you know what? Let's be specific here and focus in on how the childhood, or I'll put it this way. What recent changes, and by that I mean we have a new administration, we have a new head of the FDA, we have all this stuff going on. What changes has the ACIP made to childhood vaccine schedules, and what drove these changes? We should mention these aren't the same people that were there 6 months ago.
This is true.
Totally different group, right? And also there's some questions about whether this group fits the description you gave a minute ago about certain professional. I'm trying to not be political, but they seem less expert than perhaps in the past. Let's put it that way.
Their qualifications are not the same as the previous people that were there. Right. You're not wrong. Right. They're different. And does that make it worse? It's hard to say. And that's the hard part here, because better and worse are difficult words to define. Yeah. Does it make it less scientific in some cases? Yeah. There are fewer people that are well-versed in biostatistics and epidemiology. There are more people that are political appointees. And that is the accusation that has been made by a lot of different healthcare groups. And one of the biggest changes, one of the only changes that has been concrete that has come down so far, because they're still making a lot of the other decisions, but one of the biggest was limiting COVID vaccination to those over age 65 and not covering it for pregnant women and for children. Because they are saying that it is not recommended, I shouldn't say covering, but recommending. If it's not recommended for pregnant women and children, that means most insurances aren't going to cover it. So now if a pregnant woman wants to get a COVID vaccine to protect herself and her unborn child, she is not going to get it paid for by the insurance that she has, regardless of the insurance type, because if it's not on the ACIP schedule, then insurance is usually not going to pay for it.
Okay, so the fact that it's not just that they're not recommending it. They're not saying, let's say in the past, we recommend pregnant women get it. We've deemed it's been deemed safe by study after study, blah, blah, blah. You're good to go. Instead, this time they're just refraining from that recommendation. And that's enough for insurance companies to say no.
Absolutely. If it's not on the schedule, the insurance company doesn't have to. There's no mandate. The way that the law is mandated to cover preventive care is that if it is a recommendation of those governing bodies that it is preventive care that needs to be done, then insurances are almost legally required to cover it in some way, shape, or form.
Wild.
If it is not on those schedules, then the insurance doesn't have to cover it and nobody has to pay for it, which means that now the patient has to pay for it out of pocket. And those vaccines, because they're so new and because of the way that they were created, they're incredibly expensive.
Oh, yeah. They're not cheap. I can tell you that. I think I did a little checking on this because we were like, all right, well, we want boosters this year. We ended up getting COVID, so we've skipped a booster. Mm-hmm. And because we had it was relatively mild, we were like, well, we got the 3-month bumper. And then in that 3-month bumper, these changes happened. And so now we're like, well, if we go to a CVS or something, they're going to turn around and say, how much cash you got?
Pretty much. It's going to be $300 or $400 to get the shot. Most likely.
Oh my gosh, that's ridiculous. All right. So again, that's
the biggest change.
Yeah. All right. So that's the largest change. And you mentioned a case of adult women pregnant, blah, blah, blah. Kids, though, little kids, they're all going to school. They're all sharing their measles and licking each other. How does this affect them? I assume. Oh yeah, you want to bust that myth? They're not licking each other.
No, they are. I wish it weren't true. Oh. My point was more. Yeah, the measles thing is a big deal because we've had more cases now this year than we've had in the last 30.
That's insane.
It is, and the mentality of the folks that were there. If you really want to go watch it, there are about 9 hours of the meeting of the ACIP from this past couple of weeks that are online on YouTube. You can go watch them. I sat down and tried to, and I made it through about 20 minutes before I started getting really angry and turned it off. Suffice it to say that the chair of that committee right now is a vehement opponent of any of the COVID vaccines, and is also somebody who has a allegedly squishy background in science to begin with. And so he started off the entire meeting with some very political statements rather than the apolitical body that this is supposed to be. He made some statements that were not in line with the science and with the consensus of scientists across the globe, except for this very small vocal minority that have decided that whatever they say is what's true, not what is actually happening based on the numbers and the statistics.
Do you think this is more of a Jerry question and not a Dr. Tolbert question, but do you personally think, given your knowledge of the way this business, quote unquote, the business of healthcare in this country works, is there a path back from this? It's almost literally a political move to reset it to be a non-political body.
Yeah.
Which is a weird thing to say, but that's what you do. And someone takes it to an extreme, you pull it back a little bit. But do you think the pullback can happen? Can we get back to like a neutral place at some point?
I think it can happen for sure. And I think because this body is changing so often is probably the best way to put it. It's not every single year, but oftentimes people rotate off and on this committee.
Yeah.
If things politically swing back a different direction, even if it's just toward the middle, which is what I would kind of hope for, there is a high probability that people that are well-versed in the science are going to become members of the committee. But that takes the person that makes the appointments being willing to appoint people that understand biostatistics and science, and not just a bunch of people that are political friends or political that they agree with on a political scale.
Yeah, political
As
appointees.
Jerry, I would also say that the money involved here is important.
Yeah.
And that's true in all of healthcare, but especially in vaccines, because there is a whole lot of money in vaccination that is directly related to government contracts. So it's not that doctors get kickbacks for giving vaccines. That myth, I have no idea who started it, but I would love to figure out where they got the idea, because
I think that's true of everything a doctor does. Like if you came to me and said, Scott, take some Tylenol, somebody somewhere's going to say, well, Tylenol. Jerry's got big Tylenol in his back pocket or something like that.
Or I'm in their back pocket. Yeah. The problem with that idea is that we actually lose money on vaccines more than we gain money on vaccines. We are paying thousands of dollars for them. We have to store them. The storage requirements are such that you have to have monitored refrigerators and freezers. If those monitored refrigerators and freezers malfunction in any way, shape, or form, let's say somebody leaves a door open a crack, and that changes the temperature inside that freezer, that vaccine may no longer be viable. And you just spent $6,000 on the vaccines that are there. It's multiple doses for multiple people, but it's several $1,000s. Right. Now you have to buy that again because you can't use it anymore.
You have to toss it.
So
it's all because Janice from accounting couldn't remember to shut a door. Gosh dang it.
Accidents happen. And so yes, people need to take responsibility when they make an accident that big, but at the same time, it's still not safe. Regardless of why, it is not safe to give a patient that vaccine because it may not work at that point.
Right.
And so we don't want to give somebody something saying that it's going to be helpful and then it's not. That is part of the science that we're talking about here. We don't want to do that. And that is what we try to have in mind when we talk about these things. And we don't just give vaccines for no reason. And we don't just give them because we want to or because somebody is paying us to. We're giving those vaccines because we want to make sure that we're hitting the right milestones, that we're hitting them at the right time to give the maximum amount of benefit. The reason that measles vaccination can last so long is because we're getting it early and our fledgling immune system is really good at responding and keeping that response for decades if it needs to.
Right.
So that's why we get the MMR vaccine at a young age. We start the first of that series is given at a year old.
Oh, I didn't know that. That's early.
Yeah.
I mean, I think I was a little tiny kid when I got most of the vaccines I got, although the measles vaccine may have come. If I had to get a shingles vaccine recently, did that mean I didn't have the...
So, no, that's for chickenpox. So that's
I got it mixed up. Chickenpox. Yeah, that's why. I keep putting measles and chickenpox in the same boat, and they don't belong there.
Well, kind of. I mean, as far as the type of virus they are and symptoms and other things, they're similar. They're not the same, but they're similar. And so, yeah, they fall under the same category because the varicella can absolutely cause some nasty things to happen, especially in adults and in pregnant women, just like rubella and the measles can cause in children and pregnant women significant disease. There's this idea that these childhood illnesses are simple things because so few people that are alive right now actually experience those childhood illnesses in any way, shape, or form. There's a whole generation that, they may have seen 1 or 2 measles cases in their area in the last 30 years. Well,
you just illustrated why why the measles thing is so stupid, because this is a human problem, because we forget because we don't know. Or we forget because we weren't the ones here with polio and barely being able to move and our grandparents dying early, all that stuff. All that stuff comes, it fixes this. It puts society and humanity on a longer lifespan and a brighter future. But then generations pass, and then those generations get a wild story on the internet and go, wait a minute, what if that's true? It breaks down, and before you know it, we have 1,800 cases of measles, more than we've had in 30 years when it was essentially considered eradicated. That's an us thing, man. It's like wars. If you don't remember the war, you're going to have another one. Like, that's just the deal. So I don't know how you get around that, other than hopefully sane minds prevail and we have discussions like this and people can make their own, take their own action, do their own thing. But yeah, I can't even imagine having the measles in 2025. Is polio next? Are we all getting that again? What's going on there?
I sure hope not. It's still around, and that's the hard part. Things that we've called eradicated. Smallpox is essentially gone. It's not out in the wild. Measles is still in the wild, especially in countries other than the United States. And now in the United States, even, we're seeing enough cases that they're talking about discussion of reversal of that idea that we had eradicated it because we'd had such low numbers.
Yeah. Sounds like maybe we kind of deserve it.
Yeah.
Take it off the eradication list,
You're not wrong.
Yeah.
So, but the idea that these diseases, people talk about, you mentioned this a lot in different contexts, but the idea of consumption, this idea of tuberculosis,
right?
And it's an old people disease, or it's an 1800s disease, or it's a Victorian era disease. Tuberculosis still kills thousands of people a year. Yeah. It is a big deal. Yeah. And that is even true in the United States. There are still people that are contracting active tuberculosis in the U.S., or even latent tuberculosis, which is a little bit more insidious because you don't have symptoms, but you could eventually if something were to go wrong.
Yeah.
So there's still risk to a lot of these diseases. And we think that because we are so advanced and our science is so far along that we have all of these things under control because we aren't seeing them at a level that you would have seen them in the 1800s.
Sure.
But that's not the case.
What I like about the 1800s and that era of tuberculosis was that we gave it funny nicknames and lunger's disease, and he's coughing, he's got the what they call it? Shoot. Consumption, yeah. You got the consumption. You need to go to Arizona, the drier climate, whatever. Yeah. All these pseudoscience, ridiculous things. There's something about all that is comforting because they knew no better. And so you just did it, and you called it some funky name. Oh, the neighbor up the road's got the beaver's teeth, whatever that is.
The dropsy.
Yeah, the dropsy, the vapors, whatever it is. And you would just, what happened? She died horribly in the night 2 days ago. How old was she? 38. Well, that's just the way it goes. Good thing they had 9 kids. Then the farm's got 4 people that survived. Like, it's horrible and it's ridiculous. Mm-hmm. But I get why some people think it's comforting to not know about all these little microbes that are eating your soul. You know what I mean? Just a thing I think about sometimes. That's all.
It's valid. It's also something that we have to be very careful of because they haven't seen it, so they don't know what to expect. No. They don't know what to be afraid of.
No. I wish that was the thing about COVID. I wish you could the whole time. One of the aspects of COVID was it's bright neon green, so you know when it's in the air and you can see it floating about trying to find new hosts. Man, we would have had a really great pandemic of shutting it down.
It also would have been easier to get away from it, so it wouldn't be a very effective virus if it did that.
Yeah, exactly. Have that thing die on the vine. Mm-hmm. This will forever kill me. I know you can't manage 8 billion people. I know it's not possible at scale, but there was a week there where if everybody would have stayed inside, sick people work it out. They either die or they get over the virus. People who don't get it, they stay isolated, and everybody don't move. let's say 12 days. Just this one time in human history, everybody just sit still for that long.
Yep.
If we could have done it, COVID doesn't exist. It's gone.
Yep.
But we can't, can we? This is how dumb we are as people. What a bunch of sheep. Anyway,
well, so in defense of the people that felt like they needed to do something, it is hard to, when you are not the one being directly affected, it is hard to see the magnitude of what is happening.
Right.
And I firmly agree that we have to take into account all of these other factors. But yeah, you're not wrong. If we had sit still for 12 days, and it may have been 12 to 14 days, but either way, we didn't know at the time. We wouldn't have had any idea. But it absolutely could have made a huge difference. However,
but we can't do it. We don't know how to do that. We can't do that.
We don't. And with these new issues that are coming up, there are things that we've already done that math on. Mm-hmm. So we didn't have, like influenza right now, 10 to 17,000 people a year on average over the last decade or so die in the United States from influenza. It is a vaccine preventable illness to some degree. It is also an illness that isolation limits the spread, but we have decided as a culture that there's just a level of attrition to having influenza being around that we just allow for. Yeah. So 10 to 16,000 people a year are going to die. And we're okay with that as a group.
Yeah.
I'm still not a huge fan of that either, but again, that is the same level of thinking. It is the same process, but it's much larger scale when we talk about things like COVID-19. Mm-hmm. The same thing is becoming true with things like measles at this point. There are people that are saying, well, it's not affecting me or it's not affecting people I know, so I'm willing to let other people get sick because I don't want to do this thing.
Yeah.
It inconveniences me or I'm afraid of it, which fear of what's going on is usually the number one reason. Whether people cite religious beliefs or other things, it is mostly fear. It is this idea that I don't want to hurt somebody in the name of trying to help them. And I fully understand that. So when we talk about this, there's a lot of shared ground that we have with folks that are anti-vaccine. There is a problem, though, with letting that be held on the same level as the scientific research that we're talking about. So having a feeling about something is not the same as understanding it on a molecular level.
Right.
Those are two very different things. Right. And when we talk about the ACIP is about that molecular level. It is about understanding what is going on with those vaccines, how they work, how they're used safely. It's okay to have questions. It's okay to ask questions, but at the same time, you can't just expect that the answers will always be what you want to hear ahead of time. So you have to be willing to accept the answers when the answers come back in a way that don't agree with what you believe. And that's true for all of us. Right. That's true for the people on both the vaccine side and the anti-vaccine side, in that we need to all understand that sometimes, yes, it may be too much or it may be wrong to give a vaccine in a certain way at a certain time. It also may be that these vaccines are doing exactly what we expect them to do in the way that we expect them to do it, and that the research that we've had so far is still accurate.
Right.
And it's hard sometimes to admit when that's the case if you've already presupposed that there's a problem.
Yeah. And then you set yourself up, though, because then when some small thing happens, they're like, oh, we're making a tweak to it this year. Why? Well, it turns out it was less effective in this age group, and with these changes it will be. Oh, so you're saying the vaccine didn't work for you, and then now you're going down a path again. It's really, really aggravating, because if you just look at the math on it, we saved so many people with that vaccine. So many people got saved. And a lot of people died, and some people with the vaccine, it was still so severe they died too. But you look at the math on the whole, and it was just like a massive, almost miraculous, like, man, people can do cool stuff when we really put our heads to it, you know? Mm-hmm. And that was one of those moments. And I hate that we can't, I don't know, like, I hate that we can't do that anymore, or that we can't find that common ground. And if ACIP is going to be now a whatever direction they want to lean organization, and I do fear that, by the way, that even if a different administration from a different party comes in next time and pulls it way too back that far that way, we got the same problem, right? Maybe not the same results.
That's absolutely true.
Same problem. Yeah.
Absolutely true. And there's no one... The problem is medicine shouldn't be political, just like medicine shouldn't be business, but we get folded into both, and we don't really have a choice because of everybody else around us, kind of like what you were talking about.
Right.
And so because of that, we have to understand that there isn't room. we are not defining our terms correctly a lot of times when we talk about this in a political sense. Because what you said about people being saved, that has a very specific meaning to each group.
Right.
And if those meanings don't overlap, if I say saving somebody and you say saving somebody and RFK Jr. says saving somebody and we don't mean the same thing, then that's where a lot of these misunderstandings and disagreements start to occur.
Right.
If they say, well, people still got sick.
Yeah.
You said they weren't going to get sick. No, what we said is they weren't going to go to the hospital. Now, if somebody said they weren't going to get sick, they may have said that. They may have been wrong about it, and we may, have to backtrack on those statements if we find out that that's not accurate. So we have to be careful how far we go when we're talking about things to begin with. Communication is the key to all of this in terms of getting people to agree. But if I say death is my cutoff, they did not die.
Yeah.
And you say, well, getting the disease to begin with is the cutoff. Well, we are no longer in agreement about anything we're talking about, so any conversation we have is going to be pointless.
That's a great way of framing it, because I think that is exactly where we're at. That frame moves, right, to different extremes and different levels. But like you said, if you have too many definitions of what that means, you're never going to come together.
Right.
Or if you are, it's got to be through, like you said, reasonable communication.
I got to find the overlap.
Yeah, I think it's just going to be. It's going to take us some time. It may take humanity and complete whatever. I don't want to get. I get so like I am an optimist about the future. Generally speaking,
For sure.
I feel rising road is the truth. I feel like we improve. We have dips. We have problems, but we get there. But man, sometimes it's just like, gosh, dang it! Did it have to be now? I got kids, man, and two of them have kids, and that brings me to my next and possibly our final question today. How does this affect the many parents who listen to the show who have little kids, who are trying to make good decisions for those children, entering public school systems that are chock full of people and little kids with a million diseases, and not knowing if the ACIP says in their recommendations if little juniors should get the polio vaccine or not, or whatever it may be? What do you tell those parents, or what should they be doing as a best practice right now?
Well, the short answer is until they change the full recommendation, we're not changing anything at all. We're keeping the original recommendations we had. The childhood vaccine schedule that we had from this past year is staying in effect until they put something out that keeps the insurance from paying for it.
Okay.
So that's number one. So as of right now, keep doing what you're doing.
Okay.
The second thing is all of the organizations involved that are being affected, American Academy of Pediatrics, the American Academy of Family Physicians, the American College of Obstetrics and Gynecology, the American College of Physicians, the American College of Surgeons, all of those folks that have stake in this game that want people to be safe are already kind of pushing back on some of these recommendations and looking at ways to continue to get things covered the right way based on scientific principles. So there may be alternative schedules that are out there, and that may give a way in for the insurance companies to cover those vaccines going forward if they are delisted by the ACIP. But we have a pretty good idea, and it hasn't changed drastically, about the basics of what we would do for small children. So from that standpoint, that's probably going to stay fairly similar, even if this current ACIP comes out with new recommendations that don't match the science.
Gotcha. And also there's this other factor where, I guess maybe I've given too much weight to the idea that the recommendations go to doctors and that's it. It sounds like it's more of how it affects insurance, which obviously affects people's choices on what treatment they get. But a lot of doctors, mine included, have said to me, listeners and things, I guess I haven't asked you this directly, so maybe you can answer it, and you don't have to if you don't want to. But a lot of them are like, well, I'm still going to recommend what I know to be solid science and smart choices for my patients. Like, my patient is first. These recommendations, when politically maneuvered, are not going to change my healthcare recommendations. Again, taking insurance out of the picture, that seems like a good moral stance to take if you feel very strongly that these are the wrong moves. At any point,
it's not
can
just
they?
A moral. Go ahead.
I was going to ask you, is there any point where they can just like force doctors to do it? You know what I mean?
Nobody can force us to do anything in the exam room itself. They can disincentivize us from doing it. They can fire us for doing it, but they can't force us to do anything.
Okay.
There's an ethics committee in almost every single organization that's going to handle a lot of those things, and you're going to see massive lawsuits if something like that were to come about.
Right.
However, I'm going to say, you asked about my opinion, quote unquote. I try not to talk in opinion much because opinion is kind of the worst kind of science. Yeah. It's the lowest on the level. What I think and how I feel, it doesn't really mean much. Yeah. In terms of the science, in terms of what the data show us, I have an advantage. That whole biostatistics and epidemiology thing I did back in the master's program, I have the advantage of being able to look at these studies and say, does this actually tell us what they're saying it tells us? Is it saying the things that they're making statements about? Does it fit? Does it actually, do the data actually show that what they're saying is true and is happening on a large scale?
Right.
And so that's what I trust in. I'm one of the nerds that when the new vaccine schedule comes out, I try to read the whole thing. I try to understand it the best way that I can. And I try to make sure that I look at any changes that were made in the light of those studies and why they made the change.
Yeah.
That's not everybody. I get that not everybody has the time or the inclination to do that. And we already talked about defining terms. Try to get people to do math. That's even harder. So from that standpoint, yeah, I do feel like there are going to be a lot of doctors that are going to stick to the things that they know. They're going to be relying on those of us who are looking at the science and looking at those things from a trying to be objective as possible perspective. And they're going to want to know, what we think and how we feel about it. But at the same time, the numbers are what's going to tell us what's safe and what's not, and the safety of our patients should be our paramount concern, regardless of the political consensus that is coming down the pipe.
Sure. The Hippocratic Oath. I want to ask you a question about that real fast.
Sure.
You always hear about it in TV and movies. It's like, I took the oath. That means do no harm. And
actually not, but keep going.
We got another myth to bust here. So
yeah.
Well, A, tell me what it really means, and B, is that a thing? I know that you intrinsically feel this because I know you well enough as a friend and as someone I observe, but is there a thing, like a written or otherwise, where doctors are all like on the dotted line, I will not hurt people more than I help, or whatever, that whole thing, how mythological is that?
So it's real. The Hippocratic Oath is a very real thing, but first do no harm is not part of the Hippocratic Oath.
Wild.
It is a principle of taking care of people, and it is a principle of medicine that we have all kind of adopted, but it is nowhere in the true Hippocratic Oath.
Okay. Wild.
So we can do a whole episode on oaths. There's something called the lasagna oath that we sometimes use in medical schools after graduation. The original Hippocratic Oath is kind of outdated at this point.
Sure.
So
Hippocrates is forever ago.
Yeah, it's thousands of years at this point.
Yeah.
So there's a lot about slavery in there that we can't necessarily translate into today's language. Yeah. So from that standpoint, yeah, we do take an oath when we graduate, and we say that we're going to take care of people and that we're going to not share our art with, that's part of the Hippocratic Oath, is not sharing our art with the unenfranchised. So people that aren't doctors, we're not going to tell them our secrets. That's not something that we hold to either. So there are parts of it that are so outdated that they're not useful. There are other parts of it that do take into account taking care of people. And I think you're hitting the nail on the head when you say it is a very person-specific kind of thing. Yeah. We have to, as people going into it, if you're a moral person, you're going to come out still the same person. You may have had some of your desire to help people beaten out of you over time.
Sure.
But at the same time, the morality that was there going in is the morality that is there coming out. It's just tempered by all of the work that you've done to get where you are.
Good point. I've seen The Hand That Rocks the Cradle. I know how south things can go. Here's another thing. Just debunk this. This will be a fun little ender for us today on a relatively serious topic, and that is this. How real is the thousands of times I've seen this in TV and movies where people have to have their shoulder socket put back into place while they're laying there, and it's super painful. But it's always like, all right, pull it, put it in, pop, and then you have to do it. And then they can go on and keep shooting or whatever. How realistic is the movie pop it back in trope?
The pop it back in part is fairly realistic, although the amount of function that they have before they pop it back in a lot of times is a little bit exaggerated, and the amount of function they have after is incredibly exaggerated. You aren't going to go back to shooting with that arm. The problem, especially with a posterior dislocation, is that you can tear several ligaments that are holding your shoulder in place. And so if you held up a gun and tried to shoot it at that point, you would just dislocate your shoulder again.
It would just fall out.
Yeah, it would just pop right back out.
Okay.
So
this is what I thought.
That's the risk there.
I'm glad I thought that, because it means I have a logical brain and it makes sense to me. But it really annoys me when I see it, because I'm just like, oh, one of these again. We doing this again? You know, pop that arm back in. I had this done to me when I was 14. I smacked into somebody while I was riding an inner tube in the snow, and I hit them so hard it popped my shoulder out of the socket, and they had to do that very thing. Kirk, and it was terrible.
Yep.
But you know what I didn't do for about 8 weeks? Much
Move
of
the arm.
anything. Yeah.
Yeah.
That was rough, man. Well, anyway, here we are.
So dislocations in general, that could be its own whole episode. The amount of things that people think can dislocate or do dislocate, and the amount of things that actually dislocate, the mismatch between those is wide.
Yeah.
Things don't typically dislocate just out of the blue. So dislocating a rib, really, really, really hard to do. Very rare.
Yeah.
Dislocating a hip happens, but also pretty rare. Very damaging.
Very
to the socket when that
debilitating,
happens.
right? Yeah.
Exactly.
Yeah.
Dislocating a shoulder, a little bit easier to do, and depending on the direction, if you dislocate anteriorly, you tend to break the collarbone. You tend to do a whole lot of damage, potentially nerve issues.
Oh, geez.
Posterior dislocation is less. It's still traumatic, but it's less so than an anterior. So there's a lot there. It's a whole other discussion.
Don't expect to get up like John Wick and revenge your dog after one of these things. Okay?
No, not at all.
Quick reminder, folks, that we are easy to contact here on the show. All you got to do is go to themedical.show, and you'll notice my nice, neat little background I made, by the way. It's
I like that.
Fancy, right? If you're not seeing the video version of this, I did a little treatment on the site, and it's nice to look at. But anyway, you go over there, and there's lots of ways to subscribe to the podcast, Apple Podcasts, YouTube Podcasts, Spotify, just a regular old RSS feed for your favorite player, whatever it is you want to do, it's all there. And the best part about this is there is a form right there that you can fill out and ask us questions. You can also send us voicemails and texts on our voice line at voicecast.app/medical. It's all linked to there. You can even listen to the show on that page if you want to. So for anything you may need in and around the podcast, you'll find it at themedical.show. I think that's going to do it for us. Any parting advice before we go, Dr. Tolbert?
Don't dislocate your shoulder and then try to shoot somebody.
Yeah, it seems like an easy one to say and, like obvious, but I think it bears repeating. Don't do that. And don't get the Lunger's disease if you can help it either. All right?
Yeah, cover your coughs, wash your hands.
Yeah, and I don't think moving to Arizona is going to solve your problem. Anyway, that's going to do it for us. Thank you all for listening. We'll be back next week. Keep that feedback coming, and we'll see you then.
Frog in Pants. If you're looking for something froggy smooth, find more at frogpants.com.